All right, I think we're going to go ahead and get started. So thanks for joining us today. I'm Kate Berry, CEO of the National eHealth Collaborative, and hopefully you are all here for the golden rule of mHealth tools. That's our program today, and it's going to be really just a very informal conversation. So I'm going to kind of just make some introductory comments about what National eHealth Collaborative is and what our involvement is in mobile health and patient engagement and some activities that are relevant to that. And then I'm going to introduce our panelists, and we're going to have each of them some remarks around mHealth, sort of the landscape as well as the policy environment, and then we'll sort of open it up for discussion and questions. So that's kind of our plan for today. So I just wanted to, again, start with a little history on the National eHealth Collaborative. So we are a public-private partnership. We were formed by the federal government, the Department of Health and Human Services, a number of years ago, about 5 years ago, and we spun out from the government as an independent nonprofit organization with a mission that is very much focused on advancing health information technology, widespread adoption of health information technology to improve health and health care. So that's sort of our whole mission in life. And what we typically do is convene diverse stakeholders in healthcare to work collaboratively to tackle barriers and accelerate progress toward widespread health information technology, as I said, and with the overall objective of improving healthcare and health care. So within that very broad mission, we focus on three areas. We do a lot of work on health IT education, so a wide range of topics, mostly web-based, but also some live events. We also do a lot of work on health information exchange. So trying to figure out, how to enable widespread health information exchange. And then the third major area of focus is the whole area of consumer engagement in eHealth. And as part of that, what we've done for the last couple of years is convened stakeholders around collaborating and coordinating programs to get patients more engaged in their health care. And we've worked closely with the Office of the National Coordinator for Health IT on their consumer engagement strategy, sort of the Pledge program, and working to get the word out about that and supporting those efforts and getting more folks involved. Very, very recently, in the last couple of weeks, we've released some brand new patient engagement sort of programs, if you will. The first we announced the Monday before Thanksgiving, and this is called the Patient Engagement Framework. And so this is the culmination of probably 9 or 10 months worth of work across the industry with many, many stakeholders contributing to and iterating on this patient engagement framework. And what the framework is essentially a description of the characteristics, or it's sort of organizational in nature, but it's a description of the characteristics or attributes of patient engagement and the phases an organization would progress through in making progress in that direction. So it sort of builds on the capabilities, starting kind of, let's say, at the low end, with simply sharing information with patients or helping them navigate their way through the health system, and then building up in capabilities to, giving patients access to their medical records, enabling the system to receive patient-generated health data into the system, creating e-health tools that people can use to become much more engaged in their health. So obviously mHealth solutions are a part of this process, and sort of building up into a truly patient-engaged or patient-focused system that includes care coordination. It includes connecting all the caregivers or other community partners that a patient may choose to share their information with. So it's sort of, again, the patient engagement framework is this description of the characteristics and the phases of patient engagement. So we think we hope it'll help people kind of figure out, what is this and where can I get started and how can I make progress in the right direction? And then in alignment with this patient engagement framework, we also just recently released what we're calling a consumer e-health readiness tool, which is an online survey instrument that has sort of questions around all the sections of the patient engagement framework, so kind of the characteristics of inform me and engage me and empower me and partner with me, but then also incorporating questions around the infrastructure that's necessary to support that and the cultural, sort of the culture that's necessary to support that. So that online assessment tool, or this consumer e-health readiness tool, is essentially something an organization can subscribe to for an annual fee and then utilize to understand where they stand on that broader patient engagement framework in order to prioritize their improvement efforts and also to measure their progress so they can sort of track how they're doing in that regard. So that's sort of the National eHealth Collaborative story. And our sort of major recent breakthroughs or recent announcements around patient engagement. And we think together the patient engagement framework and the consumer e-health readiness tool can bring some pretty concrete resources to the market to help people really figure out what this is and almost have like a roadmap for how to move forward and make progress. Because what we've seen is, this is a rapidly changing field. There's a lot of uncertainty and confusion and all of that, and so what we're trying to do is kind of create both a roadmap and then some tools to help folks move in that direction. So next, what I wanted to do is, sure.
Interrupt. I think, for those folks who aren't familiar with the NEC, and frankly, I wasn't probably until a little less than a year ago, Kate, it might be helpful. They have an incredibly impressive board, and Kate has an incredibly impressive background. Perhaps you could walk through your own background a little bit and tell us a little bit more about your board. I think it'll put things into context. They're great leaders driving this very important organization.
Oh, sure, Mark. Thank you. So I skipped any real introduction. So I have 20-plus years in the healthcare industry. I grew up in management consulting, so doing strategic planning with healthcare systems primarily, integrated system development, physician hospital strategies, managed care strategies. And then transitioned to a number of different nonprofits with the National Office of the American Red Cross back in the late 90s and early 2000s. And then I was with SureScripts, the National E-Prescribing and Clinical Interoperability Network, for 7 years, sort of from the very startup of getting the network built and getting the very first e-prescribers on the network to, I left just a couple of years ago and we had, 400,000 physicians on the network almost. So to be a part of a startup, and that was, by the way, my first foray into health IT at all. So it's interesting to see how the technology can really, truly change the practice of medicine. And I think e-prescribing actually is a pretty good example of a pretty simple mobile app, So that's kind of my history. Came to NEHIC just about 2 years ago. And in terms of our board, I really should have mentioned that. So we do have a fabulous group of industry leaders on the National eHealth Collaborative Board, including sort of healthcare experts, health IT experts, leaders of health information exchanges, leaders of patient safety organizations, as well as some government folks with us. So folks may know Janet Corrigan, who ran the National Quality Forum. We have Laura Adams, who's a prominent leader of the Rhode Island Quality Institute. Thomas Fritz, who's the CEO of Inland Northwest Health Services in the Upper Northwest. We've got Chuck Parker, who I know is, I think, speaking in a competing program right now, who has a wonderful background in healthcare. He currently runs the Continua Health Alliance, which is an organization that has been working to set standards and enable connectivity and exchange among essentially devices to enable remote monitoring and information flow in that regard. So that's just a few examples of some of our leaders, but we have folks from the VA and folks from the Office of the National Coordinator for Health IT who serve who participate in our board leadership as well. So it's a pretty impressive group. It's humbling to be a part of it. So next, I wanted to really just sort of introduce my colleagues here and kind of turn things over to them. To my left, we have Mark Stevens, who joined Digital Collaboration Solutions as Vice President just earlier this year. And prior to that, he was Senior Director for eHealth Innovation at World Congress and has also headed up the Pennsylvania eHealth Collaborative. And so I'll give Mark a chance to chat about the landscape. And then we also have Robert Jaron, who is Senior Director of Government Affairs for Qualcomm Incorporated. And he represents Qualcomm in regulatory matters relating to wireless health and life sciences. So why don't I just turn it over to Mark to lead us off with some thoughts on the landscape for mobile health.
Great. Thank you, Kate. And hi, everyone. We'll try to make this lively and interactive. I know everyone's coming off some great presentations, a lot of great information, and hopefully a good lunch, too. I, too, am humbled to be up with this panel, and I've had the pleasure of working with Jaron on a couple projects and conferences. And our goal is to share stories about mHealth. You've heard a lot. We actually, again, we want this to be interactive. We want to learn from you. But just some quick thoughts on macro trends. And some of this may be repetitive, and I apologize for that. But I think we all know that mHealth is gaining momentum. And I think, some of the perspective I bring, in addition to the work I'm doing now with a private vendor, I did run the Pennsylvania eHealth Initiative at World Congress, and for the initiative, I also put on a number of different conferences around innovation. I held the first Innovation Exchange Conference with ONC, with then Director of Innovation Will Yu, just about 2 years ago. The intent of that conference and a lot of the innovation work I've done since then is to bring early-stage entrepreneurs together with potential business partners, in this case payers and providers, but also investors. So from that perspective, we've got a bird's-eye view of some of this developing technology, and it's been really cool to see mHealth develop so robustly, so quickly, and find acceptance. I've worked with an organization, we can talk a little bit about this, an Accelerator organization. How many folks are familiar with the term Accelerator? You can raise your hand. Okay, great. So I'm sure being here at the mHealth Summit, you know Rock Health. I've worked with Rock Health and a number of their companies. Jaron, I'm sure, has worked, and perhaps Qualcomm's even purchased some of Rock Health's companies. And it's fascinating to see the role of accelerators, and again, how startups, how quickly, particularly in the mHealth space, they're able to beta test and get to market. And I'm going to mention a few examples of that. But I think you look at the macro trends. We didn't know we needed a smartphone until a smartphone was developed. And now, of course, we do. And there's some really spectacular statistics as far as the adoption of mobile devices in general and in healthcare. And I'll probably tee up Jaron with a lot of these points, and I'm sure you could reference some of these stats. But I think some of the important things are not just what's happening, but how it's happening and what's not happening. So you look at drivers and you look at hurdles. What's happening clearly is people love their smartphones. Doctors love their smartphones. Patients do. And we'll talk a little bit about a patient-doctor relations. Patients are less patients, and our healthcare system has traditionally been a sick care system. It's really become more, hopefully, on the backs of mobile health and things like mobile apps, which are going to empower patients. Really, they're going to be seen more as consumers and hopefully peers in the health and wellness process with providers. So I think the relationship is changing as the regulatory, the reimbursement, and care delivery models change from the provider perspective, and help drive some of the patient engagement strategies and necessities that we're seeing on the backs of technological breakthroughs that are represented in mHealth. I think with everything going mobile, sometimes it's hard to fathom just how quickly and substantially that's happening from the U.S.'s perspective. We actually are, 10, some would say even 20 years behind not only other industries in adopting certain technologies, but certainly the rest of the world. China, India, Russia, Africa, the developing world, they're not laying landlines. Healthcare technology, information services will be delivered mobile, and it will be pretty much 100% mobile. that has far-reaching implications for any business strategy or business plans if you're developing a mobile app. And it's one of the things that's holding us back here, and we'll talk more about that, and it's particularly Jaron's expertise. But there are regulatory hurdles here in the United States, and there's cultural hurdles that we still have to overcome. As rich and as unprecedented a marketplace as we are here in the U.S., if you're going to develop a mobile app, you'll probably find proportionally more customers abroad than you will in the U.S., and that will be so for probably several years. As far as other points on the current landscape, to drill down a bit on the regulatory hurdles, I'll give you, for instance, we are past an election, a significant one, and you should all be braced for significant guidance and regulations coming out of HHS and elsewhere in the federal government over the next coming months, which is a good thing. One of the things that we've been waiting on for regulations, and again, I know Jaron will touch on this, if you look at mobile app and how it's regulated, there's the FCC and the FDA primarily. We're still waiting on FDA guidance that was promised this fall. We got a green light from Congress in July to move forward with developing that guidance, but we haven't seen it yet. If you're an investor and you're investing in a company that's launching a product into an unclear regulatory environment, you might not want to invest. You might hold back. If you're an entrepreneur that wants to develop a product to launch in that marketplace and you're savvy about it, you might also want to hold off until you get some more clarity. We think that's a hurdle that's slowing things down. So we're looking for that guidance to come out. Now that's, if you look at mobile health, you've got the FCC handling probably the bulk of the proportions of mobile apps. But mobile apps that are considered a medical device, that's what we're waiting on, and that's significant. The FCC has done its part. One of the key, I think, regulatory hurdles that was overcome is the FCC voted to increase the wireless spectrum fairly recently, within the past year, to allow for a specific spectrum for healthcare organizations to accommodate mobile devices, medical devices from a mobile perspective. That does wonderful things in a hospital room. So some of the monitoring devices you'll see today that are hooked up to wires won't be. They'll be wireless tomorrow. But where that's leading us is towards telehealth. It's clearly a nod to try to empower telehealth in this nation, and we're not quite, I would say, we're 5 to 10 years behind Canada. We cannot sustain, from a long-term care perspective, the coming avalanche of baby boomers that are aging with our current structure. We have to leverage telehealth aging in place if we're ever going to overcome the challenge of what we'll see a burgeoning long-term care population. So that's going to be key. There's a patchwork of regulation and reimbursement reform that's going to have to happen to get us out of the current status, which is holding back the market. I think a couple other major trends is, again, on the backs of this technology, we're looking at a fundamentally changed relationship between patient and provider. The patient is, if you look at a patient engagement strategy, you talk about actionable information at the point of care, which is key. With the patient and the smartphone, the point of care is often the patient and the smartphone. So doctors understand they need to get directly to the patient. The patients are going to be further incented to take control of their own health care, and payment reform is pushing things like accountable care organizations. As we move from fee-for-service to fee-for-quality and outcomes, doctors are going to look to engage with that patient more directly, more effectively, so they take control of their health care, and they stay out of the hospital, not in. So I think that's a sort of a mishmash of some of the priorities. I'll lead Jaron to add some more meat and some clarity to that. And, again, we look forward to dialoguing with you as we continue to cover some major points.
Thanks, Mark. Hi, everyone. Okay, so my name is Robert Jaron. I'm Senior Director of Government Affairs for Qualcomm Incorporated. Most people just call me Jaron, which is kind of funny because I've turned into one of those one-name people like Cher or Bono, except I'm not as rich, not as good-looking, and definitely not as cool. So anyway, having said that, every 6.5 minutes, and I want you to think about this, forget about health. Don't think about health just for a second. Entertain me. Every 6.5 minutes, you look at your phone. That's our internal Qualcomm figure, 150 times a day. Okay? So then couple that with 6.5 billion, we're nearing 6.5 billion, active mobile subscriptions. Now, that doesn't mean 6.5 billion people in the world have a mobile phone, but 6.5 billion subscribers exist. whether you have one phone and I have 5, which is the case, so obviously I'm gobbling up some of those numbers, it's still big. My point being that mobility has become the world's largest platform in the history of the world, really, quite frankly. You couple that with other figures like sanitation. 4.5 billion people in the world have access to sanitation. And the numbers actually go down from there. I'm going on memory, but I think it's like maybe 1.5 billion or 2 billion people actually have a bank account, which really surprised me. All right, so when you think about a mobile device, now I want you to think about a mobile device that's actually a computing device that does more than just connect you. It's not just making a call. It's deeper than that, at least if you have a smartphone. Of those 6.5 billion, I think we're nearing the number of about 2 billion are actually smartphones or smart devices. So that means that 4.5 billion have yet to come into this place of having a computing device. Okay? So again, the enormity of wireless, the enormity of mobility. Mobile specifically is what I'm talking about, because that's another thing. Lots of people confuse different types of wireless interfaces for, oh, it's all mobile. And it doesn't really exist. Mobile is the use of licensed spectrum, which is ubiquitous in some aspects. It's also not, because there are many places, even in the U.S., that don't have any coverage at all. When you start talking about other interfaces like Wi-Fi or Bluetooth, some of the shorter range interfaces, you start getting into spectrum that's not licensed, which means that it can receive harmful interference. Mobile is licensed, so it's not supposed to receive harmful interference, which is what gives it some of its wonderful properties. Okay, so now let's think of healthcare just for a moment, okay, and health and chronic disease in this country in particular. According to a 2005 figure that's on the CDC website, and it's the biggest source of contention for me with the CDC. I don't know how we can still have a 2005 figure up there, and that's like our figure for chronic disease, but let's go with it. Almost 1 out of every 2 adults in the U.S. has at least one chronic disease. Okay, so look to the left, look to the right, someone's sick. All right, 7 out of 10 deaths are attributed to a chronic illness in the U.S. Again, CDC figure. Okay, 600 million people, I believe it is, 600 million people today are in, I believe in let's call them seniors. Okay, in advanced stages of life. Okay, and I'm bringing that up only because it's going to come up a little later when we're in this discussion. So I want you to start thinking about chronic disease and about people that are getting old. Okay. All right, and what is the one thing that most people have with them? What do you carry with you every day? Phone. Right. What else? What do you carry with you every day? What do you have in your pocket other than the phone? Yes, there you go. Keys, wallet, and your phone. Okay, so keys are beginning to disappear as smart services begin to take over some aspects of society, right? The idea of being able to open a door, open a car door, open a home door, etc., okay, with a phone or some kind of access device. All right? Money is beginning to disappear. You can now park on the street and pay for your parking meter via your phone. Okay? There are near-field communications that are going to be coming onto the market that you can now pay for things like, a soda, for example, or, whatever at the point of service. Okay, so where's the one thing that you carry all the time? All right, so we have a lot of sick people that are carrying a computing device with them that they look at every 6.5 minutes. So now let's talk about mHealth. mHealth means a lot of things to a lot of different people. Okay, it's really a marketing term. I think the closest thing that we had to actually having a defined term from the government was in the National Broadband Plan that the FCC issued a couple of years ago. In it, they had a little tiny glossary that talked about health information technology, and one of the terms that they had in there was mHealth. Okay, since then, there has been an NIH consensus group that has gone together, and they've posted their own definition of what mHealth means. My point being is that there isn't really one consistent definition of mHealth. It's really a marketing term, and we're okay with that. Okay, because the idea is that this computing device is now your portal to tons of different information, and it also can serve as a server of sorts of extracting information from you and getting it to wherever it needs to go, a loved one, a care provider, a doctor, et cetera, et cetera. Okay? That's the wonder of mobility and the wonder of mHealth, if you want to call it that. Okay? So, I want you to think about, at least in context of the discussion we're going to have today about the U.S. and about ubiquity. Okay? According to the FCC, 98% of the land mass is covered by at least one mobile broadband network. That's important. That's an important figure. because that means 2% is not covered. We want to get to that point where we have 100% of the U.S. landmass covered by something, you know, and mobile broadband is probably going to be the way to do it, especially as we go from 3G technologies into 4G technologies and some of those differences, okay? So that's really what I wanted to say and start this off, and I think we're going to get into a much richer, deeper discussion, and I'm definitely going to speak more about the policy, regulatory, and legislative aspects of what's out there and how it's affecting wireless health and life sciences, which is what I like to call it, which includes mobile health. And one thing that I always like to do and say and clarify is that health IT is not EHR. That is a very popular misconception. Health IT equals EHR because ARA said so. ARA didn't really say that. It's been interpreted to say that. Okay? Health IT is a rich ecosystem, a very broad ecosystem, of things like a sensor or a mobile medical app or a cell phone that can you know, derive or take in health information. It's part of a network. It's part of a health information exchange. It is definitely part of an EHR, et cetera. It's an entire ecosystem that really begins with the patient. And the patient is the one that usually gets left behind when people are devising these things, which is really unfortunate. So with that, I defer to you.
Great. So I'm going to, I have a few discussion questions, and I'm sure you guys can ask other questions. And obviously, anytime, you guys have questions, please just step up to the mic and we'll go in that direction. But maybe just to kick it off a little bit, could each of you comment on, what you see as the implications of mHealth, various mHealth tools, on the patient-provider relationship and sort of on the relationship between the provider, the patient, and the caregivers around the patient?
Okay. Can we take this off? That'd be easier.
No, that's easier. Can I do that?
Well, I think I mentioned it briefly, and interested to hear what Jaron has to say, and interested to hear what you have to say. But one of the, I guess anecdotally, let's look at some of the products that are out there. Qualcomm certainly has offerings in the field that we'd all love to hear more about. I think some interesting products that have come out include iTriage. This is iTriage is really a one mobile app company, Healthogen, which was bought about a year and a half ago by Aetna. And the fact they were bought by a payer is interesting too. If you look at some of the drivers for this whole ecosystem, payers are among the most significant, not surprisingly, but the business model for payers has really changed dramatically, so much so it's been driving investments by payers in other areas. You've seen Aetna buy the HIE platform Medicity, United buying the HIE platform Accelerator. But payers are increasingly interested in mobile apps as they look to create and to facilitate patient engagement for their own purposes, if you will, and also for competitive advantage. They don't want competitive payers purchasing mobile apps, and to some degree mobile apps will be seen as sort of a product delivery system too. It's interesting that Aetna has an HIE platform, Medicity, and Medicity is now actively pushing, if you will, products like iTriage, which are also owned by Aetna. And we're going to see health information exchanges be product delivery vehicles to some extent or not. That story is yet to be fully told. I will say this about HIEs too. It's very interesting that private equity has shown interest in health information exchange. So you might see, and this will be interesting to see how it plays out because it hasn't happened yet, but you might see private equity start pricing out health information exchanges before purchase. It hasn't been done, so it'll be interesting to see who falls first, if you will, and how an HIE is evaluated and why. But I think if you look at the, going back to the original point with patient engagement, who would have known we'd need a mobile health patient engagement strategy until fairly recently? But in fact, that's what we need now as both payers and providers. And it's wonderful that NEC has come out with a patient engagement framework because a lot of folks do need direction there. But with mobile apps like iTriage, for those, who's heard of iTriage? Okay, so good, most of, does anyone use iTriage personally? Okay, okay. Well, just anecdotally, a good friend is the Chief Information Officer of the Delaware Health Information Network. That's the largest, the oldest statewide HIE in the country. Mark Jacobs downloaded iTriage, and I spoke to him a little while ago, and he said, I was on my way into the doctor's office, and I got pinged in my smartphone, and the results using iTriage and Gazelle came in. I both an indication of other specialists in my area from iTriage, and I had my lab results from Gazelle, which is a mobile app that's owned by Quest Diagnostics. Within seconds, he got an email from both. He was able to see a competitor specialist within the area who was interested because he was a long commute, and he got his lab results through the Gazelle platform. When he arrived at the doctor's after a long drive, it made him think, well, maybe, A, I should find a different specialist that's a little closer to home, and now I have a tool and information to allow me to do that. And B, when he got there, the lab results had not arrived in the doctor's office, at least not in his hands. So they were hunched over an exam table looking at his smartphone at the lab results that he had had. So I think in that case, in a real way, the patient won out in that relationship with his provider. So it's tipped the scales in terms of empowering patients in their relationship with providers. And Kate's organization had a great event last week called Crossroads, and it was about AV and e-health and their convergence. And one of the speakers made a point, and it was frankly a little bit of a downer, but I think it was reality too. There was a silver lining in it. And she said, we've gotten to the point in healthcare where as patients we should be adults. This is a business relationship, folks. Doctors are not your parents. And it's time to start judging them as the vendors that they are. Now, I'd like to see there's still a little magic pixie dust to the relationship between patients and providers, but it is important and better for all of us ultimately that we're educated consumers, and we will be because of mobile health.
Yeah, I grew up in Rhode Island. I'm Latin and Latin American, and my parents are from Ecuador. And in my immediate neighborhood, I was surrounded by a bunch of Irish guys and Italian people, and all of us spoke with our hands. So I can't hold the microphone. Anyway, the patient-provider relationship. Okay, so I'm going to try to draw concentric circles, starting with that patient-provider relationship. Right now, it's light years away from where it hopefully will be, and hopefully sooner than later. You go in, you see your care provider, and half of them will meet you with this gigantic manila folder with lots of stuff in it. They may have an EHR in the background, but they're still writing half of what they're writing down is they're writing it down. They're talking to you, which is great, because they're really that's a very important part, at least I'm told by doctors, of the entire relationship of really getting information from you. The other half now have an EHR system in the background, and they may have some kind of a teleprompt in front of them, and they're at a computer with their backs to you, and they're trying to communicate with you, but they're not really looking at you, they're not watching you, they're just listening, and they're inputting data that's based on an EHR that has these drop-down menus that may or may not really have everything that you may want to put into the EHR. Okay? So, if we go out from these concentric circles, as I'm trying to point, then you look at the health information technology world, specifically mHealth, and you have a lot of app developers, a lot of new medical device and health and fitness developers that are trying to make stuff to get to the consumer because in their minds, the consumer is interested in buying this stuff because everyone's sick, as I mentioned before. Okay? Except that we have a culture where all of us are interested in doing things that harm us, either smoking or eating too much or drinking too much or whatever, unhealthy lifestyles. So it's almost like we have to have a little bit of a shift in the culture of, when I'm sick, I'm going to go see a doctor, as opposed to, why not take care of myself a little more, or at least be more cognizant of how things can kill me, especially the things that I'm doing, and then go see my doctor when I'm sick because I know what I brought upon myself. Does that make sense? And that's one of the issues that I see with mHealth. Go ahead.
Yeah, so that circles back to money. How
Yeah, I'm glad you brought that up.
Going to monetize these products? How are you going to get an obese consumer,
Right?
who does not have enough self-discipline or interest to make a substantive lifestyle change? They want a pill.
Right.
And who develops, into that chronic disease case, whatever it may be. They're just not going to can't even monitor their own diet, never mind use an app.
Right.
And certainly not going to pay for it either. So
Who pays for it?
yeah.
Right. In our current system, the rest of us pay for it. Today. In our current system, the rest of us pay for it.
I'm not saying it's good.
Right.
I'm just saying that's.
Exactly. It's part of the problem. I wish I had an answer for you. I don't. I heard last night at a Robert Wood Johnson Foundation dinner that apparently of the 100 people that go to Weight Watchers, 90 of them fail. And their business plan is built on the 10% that don't fail. Okay? That's amazing to me, again. But there has to be a culture shift in, we're sick, we're going to go see a doctor, as to we need to take care of ourselves a little bit more. That doesn't mean that you're going to become uber healthy overnight. And it also has to translate into what developers are doing today, because I think a lot of developers are out there just saying, oh yeah, these are all opportunities, we're going to make a ton of money on mHealth. I don't really see that happening. I see it almost as a little bit of a bubble, and you know what happens with bubbles, right? They pop. So, so I want everyone to think about that when we're thinking about the patient-provider perspective, because right now I don't think there is a patient-provider perspective when it comes to mHealth. There are some very forward-thinking docs that have embraced some of these technologies, specifically health information technologies and maybe some aspects of mHealth, but that doesn't mean that large, hospital systems or large providers, meaning health insurers, have embraced mHealth. I'm really encouraged by the things that I heard at this specific conference. Aetna, for example, I thought that his keynote was very interesting, And it's important to see other companies like UHG that are definitely looking at mHealth, and of course Kaiser Permanente, which has always been a leader in health information technology. But I think that we're really light years away from, how the patient-provider interaction has either morphed or changed. It's not. It's going to change over time.
So, as a diabetic,
Mm-hmm.
I went through 5 physicians before I found one, endocrinologist,
Mm-hmm.
that would actually take a look at my blood glucose data that I brought with me. So there's
Yeah.
a really mixed market out there in terms of providers' reluctance to even consider what a patient brings in the door.
Problem number 2 is this wealth of data. Todd Park and a lot of other very well-informed people talk about the data tsunami. They're not kidding. There's going to be a lot of data, and whether or not that data is useful is still a big if. Okay.
And if I could jump in,
Yeah.
so with another related issue is integration. Health information exchanges are going to get data from all these different sensors and now these mobile apps. But we've talked with the health information exchange operators, and they say we have no way to integrate this data. So it's beyond good data in, good data out. It's what do we do with it, and how do we do it? And there will be outliers. I think Geisinger, I'm coming from Philadelphia, is doing incredible things. But Geisinger owns most of the physicians they have. They own their own health information exchange. And when I talked about an issue that I'm very interested in, and that's sort of the breakdown in the care coordination between acute and long-term care, Geisinger's solved that problem by buying the long-term care facilities in their region. Not every healthcare provider will have that, ability.
I would just add to that one, too, that this issue of, what you could call patient-generated health data, it's something that requires a policy framework, a policy framework that can help to set the right expectations on the patient side and on the provider side, and begin to sort of have some rules of the road, if you will, try to find the best possible balance between what the patient wants their provider to have and what the provider wants to have. So we're actually, National eHealth Collaborative is going to be working with the Office of the National Coordinator to try to convene folks to have a dialogue around that, so that we can find some of these examples where we're striking that right balance, where, I heard a story earlier today about a caregiver who, gathered all of the detailed medication information on, her mother, and brought that to the provider, who refused to look at it, kind of like the story you're telling. So the reality is, there's the fear of the provider getting inundated with way too much that they can't assimilate, and oh, by the way, does that introduce additional risk to them or liability? And then there's, the patient who may feel or believe that every single thing I think or feel I want in my medical record. So you have to kind of try to find the right balance. I think we see a hand there. Go ahead.
I'm a licensed clinical psychologist,
Yeah.
There's a chapter in there called Why Real Estate Agents Are Like the Ku Klux Klan. And it's about control of information. And it's about how people who have doctorate degrees or some other control of information they're intimidated by the fact that other people may have that information. And it may end up putting them either out of business or it may somehow decrease their standing in society or something. And so I think a lot of doctors are just really, they're intimidated by patients actually having information. And they're intimidated by a patient coming in with information pre-made because they look at the patient like, I didn't tell you to bring that information in. You're supposed to, I'm an expert here. What are you doing? And I think that shuts a lot of them down. I think it's kind of not politically correct for me to say that, but I think it's something we need to think about.
I'm not sure that this is exactly close to what you're talking about, but in some sense, I think I see healthcare really will be changing, and I think that the FDA is actually acutely interested in that change. For example, they had a 2-day workshop this past year, I believe either in March or April, on how certain devices in pharmacies will now be taking over some of the pharmacological information that pharmacists usually dispense or helping. It's almost like a kiosk helping pharmacists, and whether or not pharmacists themselves would be taking on a more proactive role than they do now in dispensing things. It was a hearing, so it doesn't mean that there's any kind of rule or anything like that, but those are some of the topics that they were talking about. So I kind of almost see like this interest in having health information technology and just, information technology really begin to be a little more proactive because of something like what you're mentioning. I'm not sure if the two are related, they're probably not, but I'm just bringing it up because it reminded me of that hearing. So and I myself personally think that, as time goes on, the practice of medicine will change. You're going to see more, medical assistants taking on more of the roles that docs had in the past. There is a shortage of doctors that the U.S. themselves have said is going to happen. I believe 24,000 doctors short of whatever it is, a number that they had originally anticipated by the year 2020 or something. And the same thing with nurses. A lot of that is attributed to the baby boom and some docs that are going to be retiring. Sir.
Well, CVS,
Right. Yeah. Yeah. Exactly. Yeah. Which the mini clinics are great. I use them. But to go back to something that Kate mentioned, CMS and ONC. ONC has done a lot to put in certain requirements into obviously the meaningful use. The idea of meaningful use, and really it's the CMS incentive payment program, and the requirements that are coming out of that. 15 in the original, I think 20 in stage 2, and now we're looking at stage 3. In stage 3, they finally have, as proposed, language, at least in the RFI that they issued about 3 weeks ago, which I encourage any stakeholder that's interested, please go comment on this open draft. It's up on their website, and you can comment up until January 14th at midnight. They finally have in there, under engaging patients and families, the ability to upload patient-generated data. And that's a first, and that's good, because we wanted that. We wanted that actually in stage 1. But then the question becomes, what happens with that patient-generated data? The doctor is not going to look at it because doc isn't going to want to look at 6 months of, blood pressure, cuff monitor readings, and, medical weight scale readings, etc. There has to be some kind of analytics. There has to be either clinical decision support software or other. But it's important to get that patient-generated data. I think actually even more important, because when I do talk to docs, and I've talked to lots of docs that are either in the industry or just part of my work, they tell me that that's the stuff, that's the pearls that actually give them an idea of what's going on with the patient. Because when things are going along smoothly and suddenly there's a spike or a valley, something caused that, and it's usually symbiotic with something else in that patient, and that's really important. So how do we get that little pearl out to the doc? That's really where I think things are heading. I think that one of the questions that we were considering for the panel was actually, investments in the future. I think you're going to see a lot of investments in things like sensors, passive sensors. That way you don't know and you don't have to, and it's doing it automatically for you, and analytics. Because somebody has to deal with this tidal wave, this tsunami of data.
A corollary point to that, too, I think, if we're talking about the relationship between patient and provider and the importance of information and its ownership as the coming battle over genomics. And right now, the AMA, there's two hurdles that I see coming out of the AMA, at least two. But one is their stance right now where doctors own the information, genetic information that is derived from a patient. And the thought is, again, and you could say it's similar to other passages of information, but that, well, we understand it and you wouldn't if you saw it. But we're going to see a move from population health to personalized medicine on the back of genomics. And we're going to have tailored drugs that are tailored and therapies that are tailored to our own individual needs instead of the scattershot solutions that we have now. That's fundamentally going to change medicine in a dramatic and very good way. But it's tough to write about a history when you're living it, and folks, we're living it. And this hasn't really come to bear on a large scale, but it is happening. You can, there's a number of tests out there. You could get your genetic data tomorrow. So I think that or today.
I'm scared that somebody's going to get old.
Well, yeah. So that brings up a lot. But you could be, 20 years ago, folks were scared about, wow, using an ATM card. I don't want to use it because who knows if someone could find my bank account. Or we all probably remember the first time we bought something on Amazon. We typed in our information, turned away, and hit the send. For patients, it's a tipping point, right? So if I'm a patient, I look at concerns over privacy and security that are weighed by convenience and value. And convenience and value wins out. When it wins out, that's the tipping point. We haven't seen the tipping point yet. But we also have a communal challenge, everyone in this room. We've got to communicate to patients, consumers, that there is a tipping point. And with the check processing industry, for a long time, it's been a zero-fault tolerance policy. You never have a problem with processing your check. Why aren't we there yet in healthcare? We will be, and some with encryption we are, but the value is there. I think a lot of it is just hasn't been communicated. But if you look at the genetics, this is going to be a battle. Patients have to fight to get their rights upheld, and that this information is theirs, and that battle hasn't yet been fought. One other a corollary to a corollary. I was talking to a great physician, very well-established physician in Boston recently. We were talking about telehealth and hurdles. And he said, well, here's one hurdle that you really haven't talked about, and that's the Hippocratic Oath. The AMA also holds the Hippocratic Oath, obviously, in high regard. And if you look at it, and it's a literal interpretation, so a fundamentalist interpretation of the Hippocratic Oath, it's the laying on of hands to provide care. That precludes telehealth. And that seems sort of silly that would be a significant hurdle. It is. Yeah, very major. Though behavioral health lends itself so well to telehealth.
Yeah, but in doctoral programs in clinical psychology, they talk down anything that doesn't involve face-to-face human interaction is considered. I mean, it's like a mortal sin. I mean, you're not even supposed to talk to clients over the phone.
Yeah, they must be employed by CMS. I'm going to go to this guy.
That's right. You've been standing patiently.
So with the proliferation of all these data harvesting apps that you can run on your iPhone, et cetera, for your own health and your fitness, one thing I'm concerned about is who owns that data and where it's being stored. Is it onshore? Is it offshore? What government rules and statutes is it subject to? One of the reasons why is that unanticipated results of what we're doing here just came up. I was at a healthcare IT big data seminar that I go to frequently, and it's repetitive in Chicago. And one of the interesting ones that came up is a major analytics company that's got their product in beta right now has been approached by a major offshore retailer of pharmaceuticals. And they've been, they're the ones that call you and, hey, you need Viagra or something like that, and they're calling from some weird number in a foreign market. They're very interested, apparently, in engaging this analytics company to begin to harvest a lot of these, all this data that's out in these apps all over the place that is not really being governed or managed. And they're going to really do a CRM target to people that really need a custom formulary tailored to them. And it's going to be much more interesting. And when I hear the frustration of people when they go to their doctor, my question is how interesting might that be to many patients who are disengaged from their physician because their physician won't engage with them, and to say, well, I went to this app, I've kind of done the self-diagnosis. It's a pretty good expert engine. I kind of trust it. And now I've got someone that's calling me daily to deliver the drug that this app's recommending. Is that going to change behavior in an undesirable way?
So the first part of your question is really who owns the data, and it really the best answer is it depends. It depends. It depends who's gathering your data. It depends who they're using as a business associate. It depends whether or not they're a covered entity. It depends if it falls under HIPAA or not. It really depends. Not knowing precisely what you're referring to, I can say a couple things. You don't necessarily own your own data, and that's a problem. It's a huge problem, especially if you're a care provider for somebody else and you're trying to get their data to another hospital or another specialist or another hospital system. You may never be able to get that data, and your loved one might die in the process of you trying to obtain that data, and that's not right. It's just fundamentally not right. So.
Can you please use the microphone? They just yelled at me. So they're recording. So do you mind stepping to a microphone?
I think what he's saying is there's bad guys out there with nefarious goals,
Sure.
and they're trying to sell us drugs over the
Right.
web, and if they have the ability to better target us, we're basically giving them tools to do more bad stuff.
Who's giving them those tools? There's got to be a vendor that's getting the data and selling it, and they can.
Well, who do we know who's legitimate or not? We've got to be able to certify so that I know when I go down with something off of the iTunes that this is a trustworthy.
But that's not the job of the iTunes store to certify whether or not the stuff that they sell works or not. It's really not, right? There are some regulatory agencies that do that. For example, the FTC, really in charge of consumer protection. The FDA, safety and efficacy of a device. But that safety and efficacy is very different than whether or not it actually works. Meaning, does the thing work in its intended use? Yes. Will it have a good outcome? As long as it doesn't kill you, that's what they're looking at. They're not looking at, the viability of the product, if the product actually is a good product. That's not their job. So there are other third-party kind of, companies out there that have come to line, like Haptique, for example, is interested in maybe coming up with a prescription-styled offering for mobile medical apps. That's one approach. There are others, but yeah, I don't have an easy answer for you. But really, if you're asking whether or not the good guys and bad guys or the bad guys should get the information from the good guys, that's a vendor relationship. People can sell whatever they want to sell to anybody, really.
Jaron, I wanted to sort of take that another direction. Do you think that you mentioned Haptique, isn't there a need for, since there's been this explosion of mobile health solutions and apps and all that, and the regulatory environment, while it will regulate some, and it's sort of hard to catch up. It's sort of hard to catch up with everything. Do you think there is a need for some sort of independent validator or vetter that could at least be a resource for people as they consider, is this safe? Is it good? I don't know exactly if there are standards yet for it, but what do you think about that?
I think it's a good idea. I think I think it's a good idea. I think it's a great approach. I'd like to see more companies involved in what Haptique is doing. I think they're growing. I think that the sky's the limit for them. There's a lot of interest behind what they're doing. They are, to come full circle, I know that they are partnering with Qualcomm Life. That's our medical device subsidiary. I work for Qualcomm Incorporated, so to make a distinction here, at this show, you've seen a big presence of Qualcomm Life. That is our medical device subsidiary that was launched about a year ago. They're specifically selling a platform called the TuneNet platform and a hub, both of which are medical device data systems intended to transfer, store, convert from one format or another and help display medical device data. But that's very different and distinct from Qualcomm Incorporated, which is the parent company, and that's who I work for. So Haptique is working with Qualcomm Life. I know Qualcomm Life has about 180 issued, I believe, partners, so I'm hoping that those partners will be able to partner with a company like Haptique. But I don't know if they have the buy-in of the entire industry, and all I can say is it's going to take time, and we'll see how this goes. There are other types of companies out there, organizations. For example, iMedical Apps is run by doctors, for doctors. It's basically a consumer report type thing on the web. intended to really look at some of the mobile medical apps that are on the market and really assess whether or not they work and kind of give a critique to them. And that's another form of this consumer reports approach. Someone that I was speaking with last night told me that Consumer Reports apparently has been approached to see whether or not they wanted to actually do this and really run viability studies on some of the mobile medical apps that are out there, but they declined. It wasn't big enough. So
It's interesting. I mean, I was at did a program, a panel yesterday, and a question came up. How do you make sure that the best scientific evidence available is behind these types of apps? And I think, it's one thing to look at usability. It's one thing to look at, functionality and value and convenience. But, if it's a health app, shouldn't it have some scientific evidence behind it?
And Mark, if I can continue on that thought, the evidence aspect is really, really big and really, really important. It's something that the NIH is trying to grapple with as we speak. The NIH has taken an extremely proactive role in mHealth, specifically the Office of Behavioral and Social Sciences Research. They host a training institute where they actually had it this weekend right before this event, and they're involved in a number of other things, including the possibility of starting a public-private partnership. And I think that with their help and also the interest of so many other institutions, for example, Johns Hopkins is very big in the area of trying to qualify whether or not some of these things work. I think that that's where we're going to start getting some evidence. But that's very different than a garage entrepreneur working on an app and coming up with something which may be very good. It may be excellent. But, is there rigor there? Is there evidence? The evidence is the key. So I'm hoping that that garage entrepreneur will have somewhere that he or she can go to be able to find out how to actually do the rigor, how to actually get the evidence. I think that that's really important.
Mm-hmm. So, Mark, can you talk a little bit about what accelerators are doing in the mHealth arena?
Well, I'd be happy to. And I'm fascinated. Jaron, it's great to be with you again. I'd love to hear some of the things you're...
Not what my wife said.
So most of, I think, remember, show of hands of folks that are familiar with accelerator organizations. We had, I think, one of my favorites, one of the top ones in E and mHealth here, overseeing the Startup Pavilion at the mHealth Summit, and that's Startup Health. Unity Stokes, co-founder, has been doing phenomenal things, and Jerry Levin is their chair. Jerry's also, as you recall, founded AOL, and he chairs at the President's Startup America Initiative, which was started in February, which actually works across industries to help accelerate startups and their penetration of the marketplace. What accelerators are meant to do is to allow promising startup companies to accelerate the pace of their ability to sell products into the marketplace quicker than they would otherwise. One of the things I've been involved with, I think I mentioned, I worked with Will Yu at ONC to put together the first, what was called an Innovation Exchange Conference. This occurred a year ago, last May, in Philadelphia. And by design, what an Innovation Exchange Conference does is something similar to what an accelerator does. It brings together early-stage companies with potential investors and clients, and accelerates their meeting. If you're Steve Jobs and you're still in the garage and you develop a mobile app, you're not going to get a return call from the CIO at Kaiser. However, if we put together a conference and we get the CIO there, and with what we did in our conferences, put together an expert advisory panel, we use accelerator organizations to recruit startups. The advisory panel would whittle down 100 applications to 10. We'd invite those top 10 in to present. Then they'd have a chance to talk with some of the leaders that were there to either invest in their companies or to purchase them, both payers and providers, and again, venture capitalists. So accelerators, what they do is provide education. So a typical accelerator will often partner with an incubator, and they're two different things. But accelerator, really, they're just a very high-level, quick, graduate-level, sort of a crash course in how to run a company and how to attract investors and sell your products. I think some of the Startup Health is certainly a leader in eHealth and mHealth. Many of you know Rock Health, which has been historically, though these are all young organizations, Rock Health, all of them are less than 2 years old. The leading ones, Rock Health has been focused specifically on mHealth. You have another one called HealthBox, which is interesting in that it's funded completely by Blue Cross Blue Shield Ventures. And a quick foray, again, with one of the big drivers in mHealth right now from a financing perspective are the payers. And they're driven by one, their business models sort of toast, so they're looking at other ways and places to invest. But they're also looking at these mobile apps to further their patient engagement, and they have the wherewithal to wait out for an equity moment 5 years or so where a typical organization in a startup will experience before they go public successfully or be bought. So I think, you see payers investing in those, and another one that's, I think, a great one, another one like Startup Health is out in New York, and that's Blueprint Health. Dr. Brad Weinberg, I think, was here, and he might have even had a speaking role, but he's doing an excellent job, I think in picking some of these horses, if you will. To give you an idea of volume, all right, so what's out there in terms of the ecosystem of entrepreneurs, both in E and M Health. Startup Health reported for their second class, which are 10 organizations they chose, they picked that class of 10 from an applicant pool of 693. And I talked to Unity Stokes, and you were nodding your head, so sounds like, it looks like you know Unity. And he goes, Mark, it's light years from our first class. These were 693 good applications. These are entrepreneurs that had, business plans that were worthy of, of respect and in-depth research and products that had some promise. I mean, those figures. It's much more competitive than Harvard, and it's very promising that we have that, that level of entrepreneurship out there. It's frustrating though, because where do they all go? There are accelerators that are proliferating, but not apparently enough so to meet the educational needs. I think, again, many of them pair with incubator organizations. A separate one, and that's where you have a supportive, often a lab environment that will provide the support that an organization needs to grow in addition to education. But one of the things we'll still see with these entrepreneurs is a stratospheric rate of failure. I wrote an article for an organization called SOAP, the Society of Physician Entrepreneurs, in their national magazine last month. And one of the things I would suggest that we do in mHealth, and if you look broadly at connected health, is we might want to go a virtual route. There's a burgeoning movement in online courseware, free online courseware from some of the top universities and graduate organizations in the country. I think as an industry we have to look at offering more accelerator courses to more entrepreneurs in a more affordable way. If you're a mobile app, you require very low capitalization. For instance, if you're a software company and you're approaching a VC, you're typically looking at a $50 million valuation. If you're a mobile app developer, it's quite a smaller fraction. So I think you'll see the ecosystems of accelerators change. It's a global marketplace, so I think you'll see accelerators take on a global and hopefully a virtual paradigm as we move forward. And I'm hoping that my firm actually has been tapped by a law firm who's very interested in opening up their own accelerator. It's interesting to see who's interested and why in starting up accelerators to open one here in the Washington, D.C. area. So I think look for more regional diversification and accelerators taking on different and more virtual roles.
As far as investments go, investments in the industry, last year alone, according to mHealth News, there were investments of $500 million for the entire year, and that's 2011. According to an article in mHealth News in October, according to Health 2.0, Matt Holt's group, by October 2012, this year, there had already been $1 billion worth of investments. So that definitely shows growth. That's a lot of growth, scary growth. One part of when we're talking about investments, or one place that not a lot of people have been looking at, but probably should, especially small companies and those garage entrepreneurs. I love the garage entrepreneur because I think of Bill Gates. That's what I think of when I think of a garage entrepreneur. Are actually states and state funds and state funding vehicles. For example, the state of Maryland has a technology development corporation that they've established to fund a certain amount to fund and to promote a certain amount of innovative medical technologies and technologies generally. This is a fund that was formed much like a private equity fund. There are sources of money there that may or not be going untapped, but this community should definitely know that they exist, and I'm not sure that they do. So that's one place to look at for investments, and where this fledgling field is going. I guess I'll close out my comments with regards to investments by saying that Qualcomm, through Qualcomm Life, has developed a Qualcomm venture fund specific to mobile health. And some of the investments have already been made, are made with companies like Sotera Wireless, for example, or AliveCore, who just received their 510K Class 2 clearance by the FDA. Qualcomm makes its investments for a variety of reasons, many of which I don't even know. I'm not involved in that wing of the company, but you can look to what big companies are doing and kind of read the tea leaves. I think that's an important aspect of figuring out where and why companies are doing certain things. There are certain investments that people have looked at me and said that doesn't make any sense, but it may not make any sense for the outside world, but it obviously makes sense. Otherwise, Qualcomm would not be investing in those companies. So, just be cognizant of what companies are doing and follow the tea leaves accordingly.
What do you guys think, what are the biggest barriers to widespread adoption of mHealth and the ability to realize all the benefits there? What are the biggest barriers and how can we overcome them? How does the industry tackle those?
Before we let Jaron tackle that, but before, one more point about accelerators I think is important to note, and because you brought up financing. Typically you look at a venture capital firm and they'll look at $1 million, often $5 million as really the basement for their investments. Obviously that leaves mobile health if you're developing an app in your garage in the dust. So where do they go? Obviously angel funds, and you might want to speak a little bit to that. But typically with accelerators, if you're going, what's the business model for them? And I really didn't touch on that, but when these companies get accepted into a program, let's say like Startup Health, it's typically 5 or 7% of the equity of the company that they're asked to give over to go through a 3-month intensive program and then have often a demo day where they get formally introduced to potential clients and investors. That's a pretty, for those of you in the startup world, that's a pretty significant chunk of equity. So my point, again, I think we need to look at the accelerator model and change that a bit to bring that equity level down for entrepreneurs or would-be entrepreneurs, particularly if you're looking at a nurse practitioner or a physician that's on the front line of care. Many of them have great ideas, technological ideas that could advance the industry, but it's a very difficult position for them to leave their traditional work and entrepreneurial jump. We've got to make it easier for them to do so.
All right, I'm going to Kate's question on the barriers. So I would say that the barriers to adoption are one being education, both on the part of healthcare systems, healthcare providers, doctors, et cetera, and also on the part of the patient and consumers in understanding that these things are out there and actually work. That is a huge barrier to adoption, one that not a lot of folks in our industry have yet begun to really consider. I think the Wireless Life Sciences Alliance, I hear rumblings that they're going to start looking at the consumer side of that education, which I think is important. It's really easy to turn around and beat up on agencies such as the Center for Medicare and Medicaid Services, but I will, only because I love them so much. CMS does a great job in this country of dispersing close to over $800 billion, and that's with a B, of funds for health care. $500 billion of which go to Medicare, and the rest go to Medicaid and administrative expenses. And the current system, as is now just cliche, does not incentivize doctors and eligible providers and professionals to use health information technologies other than electronic health records through an incentive payment program that has been developed through the ARA. To use these types of equipment and these types of products and services, et cetera. So that is a huge barrier to adoption. There has to be a change in the reimbursement system. There has to be a change in the financial incentives. We're really hoping that some of the things that ONC does with Meaningful Use Stage 3 and future stages will actually tackle these kinds of things by including in incentive payments these types of health information technologies such as mobile health. I think that that's a really important thing, so we'll see. Having said that, I hear a lot of stuff right now because CMS has changed the way that they are looking at hospital readmissions. For example, there are 3 very specific disease states. One's heart, 2 are heart, one's pulmonary, which if you're a Medicare provider and your patient leaves the hospital and they come back within 30 days, they'll penalize you according to a specific ratio that's built on your hospital and then a specific formula that they're in the process of formulating as we speak. And a lot of folks are like, wow, that's it, that's the beginning, because people are going to turn around, meaning people, meaning doctors, hospitals, et cetera, are going to turn around and embrace health information technology suddenly because they're being penalized. Maybe some, but not really, not many. You know, it's not a direct, it's not a mandate, not that I like mandates, but it's not a mandate, it's not an order, it's not a rule that says, you know, or gives an option of, you know, use health information technology, otherwise you're going to get penalized. I think the closest thing that we've gotten from CMS recently is in the current 2013 physician fee schedule. There are 2 codes for transitional care and non-face-to-face consultations in those codes. Now, what it says is, if you're a doctor and, you know, your person gets discharged, you have to contact them within 2 days, either directly, which in my opinion means face-to-face, or by telephone, or electronic. Now, I've asked 10 doctors if they had the choice of using face-to-face or call or run out and buy a health information technology system so they can do it electronically, which one would they do? It's not the third one. Okay, so again, it's a crack in the armor, it's a crack in the wall, which is wonderful. So CMS is beginning to think in a modern way, which I think is excellent, but it's not enough. And we need to change those reimbursement, that method of reimbursement. And that, you know, it really will take a mindset change. I get the fraud and abuse, I get it all, but there's a lot that can be done in health information technology, including timestamps, location awareness, et cetera, to mitigate some of those risks. That said, there's also the second part, which is the durable medical equipment. It has to be reasonable and necessary in order for it to be durable medical equipment, and you have to go through all kinds of things like national coverage determinations, local coverage determinations, Medicaid, et cetera, et cetera. Okay? So it's a big process to get your product on the market. I always go back, and I always talk about this in every speech I do. In 2009, there was this great article that came out in the New York Times about a woman who has ALS and her son who has Down syndrome. The son needed a very specific piece of durable medical equipment, a very specific durable medical equipment device, FDA cleared, that helped him in speech path. The laptop cost, I think in the article it quoted something like $8,000. Okay? The operating system had been masked, and it gave one kind of software so that they can use it for this purpose. The article also said that if the person, when the beneficiary actually bought it, and of course that's a reimbursable thing, therefore they didn't really pay for it, when they got it, they also would be given a little slip of paper that said, you can unmask the operating system and use the full functionality of this laptop by paying us $50 directly, and we'll send you the code. The article talked about how a smartphone at that time, this is 2009, before the, you know, massive wave of smartphone apps that we now have that are dedicated to health and fitness and mobile medical. The article stated that an app at the time, the Cadillac app, would cost about $400 and the phone cost $600. So that means that that device is $1,000 compared to $8,000, but the phone could do exactly the same thing that this durable medical equipment would do. Why? Why is that other one reimbursable? I get reasonable and necessary. We have to change the way that we think about this and the way that we approach technology. These laws were built 30, 40 years ago. Okay? They're out of date. Okay? Some of them are still good. FDA. People beat up on the FDA constantly. I like the FDA. I think the FDA is doing a very good thing. I think the safety and efficacy of medical devices is absolutely of paramount importance. And I actually think that their regulation is pretty good. Intended use, very easy. Section 201H. If you fit all these things, then you have the requisite intended use that this is going to be a device, a regulated device. Cure, treatment, prevention, mitigation of disease in man or an animal. You're in. Very easy. The part that's missing is the clarity of when you actually have a low-risk device that technically falls under that definition, will you get regulated? Will they come after you with an enforcement action and, you know, and a meat cleaver? That's where, you know, the government has to, you know, move towards and work. And the FDA has done a fabulous job of trying to do that and trying to come up with some good clarity. And we're hoping that the mobile medical apps guidance document comes out in either January or February. But CMS, much less. And that's where, you know, we really need to change, because that is definitely a barrier to adoption.
So, and again, if folks have questions, please step up to the microphones. But so what thoughts do you guys have, or stories or examples about how mobile health can be leveraged to help improve access in rural or underserved communities?
Sure. So Qualcomm has a program called Wireless Reach, which we started out in 2006. The idea behind the program was that it's a strategic program modeled after trying to facilitate social good through connectivity and reaching very specific segments of society, whether it be education, entrepreneurship, public safety, environmental sustainability, or healthcare. As far as today goes, that was in 2006. 2012, we now have 73 projects in, I believe, 31 countries. And one of those projects actually happened in D.C. I am what they call a pioneer because I live in Anacostia, which is a very statistically poor and dangerous area of D.C. I don't agree with that because I live there and we have a beautiful home and you know, I live with my wife and 19-month-old baby and you should come visit sometime. But Anacostia is just a pearl to D.C. But we started a project that was based out of the Anacostia area, and what we did was we engaged GW Medical, Cricket Communications as the phone provider using CDMA. We engaged One Economy to try to target a specific population, which happened to be congestive heart failure patients and diabetes patients, I believe. I'm sorry, congestive heart failure patients. They were looking at diabetes patients, but it ended up just being congestive heart failure. And also worked with a small app developer, which developed an app called the Pill Phone, a company called Vocell, which has went out of business, got bought by another company, and will hopefully be coming out with the Pill Phone again. The idea was that we would preload these phones with the Pill Phone. It's an app that would help people identify, in this specific instance, a Medicaid cohort that all lived in the Anacostia section of D.C. That had to use 3 or more medications. So this Pill Phone app would help them, you know, monitor and keep adherence of taking their medication at the right times. It was a very small study, only I believe 50 people or so, and it was conducted over 6 months. The idea behind the study wasn't whether or not people could get better in 6 months, but the idea was whether or not people would actually use it and people would actually like it, and whether or not the data was easy to get back to the hospital and the care setting so that, you know, doctors would know and care providers would know what was going on. We had an unbelievably very receptive crowd of people that did not, some of which did not even have a phone, that loved it, did not want to give up their device, really appreciated having this medication adherence you know, app and this wonderful collaborative you know, situation with their care provider. It really changed the way that they looked at their health. That's empowering. That's really important. Minor, small, but an example.
Mark?
Well, do you mind if I change gears?
Sure.
I think we're running out of time, and I know
Yeah.
we want to talk to folks. And Jaron has much better stats than I do, so playing to my strengths, there are 2 startups that I wanted to just bring to folks' attention, and then I know we want to open up to questions, and I think we're closing out in just a couple of minutes. But you know, all the work that I've done with startups, and I've worked with a couple hundred in the last 2 years, two really stand out. And again, if you break up startups into 2 broad categories, you could say in mobile health regulated by the FCC or the FDA. One that would be regulated by the FCC is a startup out of Canada. Dr. Joseph Cavazzo runs the University of Toronto Health Systems Innovation Center. It's a worldwide innovation center. And his team developed an app called BANT, B-A-N-T. And intuitively, it sounds simple, but for some reason we haven't developed it here, at least successfully. And it plays to your point on diabetes. This is a juvenile diabetes app that is designed through gamification to make it more fun for juvenile diabetes patients to adhere to their regimens of care and medication. It's been phenomenally successful. And again, you drive people's usage and then make it sticky. Gamification, and I think they're next door, is a great way to do that, particularly with this population, but really with any of us. And you look at on Facebook, what is it, Farmville? I mean, it's fun. So look at BANT, and I think what they wanted to break into the U.S. marketplace, they won our People's Choice Award at our innovation conference, and I think they will. So that's interesting, and that would be regulated by the FCC. One that would be regulated by the FDA is a startup called iNetra, E-Y-E-N-E-T-R-A. iNetra was founded, their co-founder is the head of the camera club at the MIT Media Lab. He's actually an Indian national, and they're beta testing this product to the company's headquartered in Cambridge in India. what this does, their mobile app, it's a retinal exam. So if you wave your smartphone in front of your eyes, it'll do a retinal exam. Their information goes right to an eye care manufacturer, and you'll get plastic glasses within 5 business days for $5 sent to your house. And the Indian National Health Service loves this, and they're thinking their first client, I believe they ended beta testing this summer, is going to be the Guangdong province of China, which a company called Ideal Life, which Canadian company was exhibiting here, phenomenal. I think they signed the largest mobile health
100,000, I think.
contract, and it was with the same Chinese province a little over a year ago. It really is fascinating. If you want to see the future of healthcare, watch where these mobile apps, what they're being developed for, and who's buying them, and who's investing in them. We talked about tea leaves. It's a great place to start.
Great. If I can just say, I want to make one, changing gears yet again, I want to make one quick plug. Representative Honda's office released a piece of legislation just this past Monday called the Healthcare Innovation and Marketplace Technologies Act, or HIMTA for short. The pending legislation, or the legislation, seeks to establish an Office of Wireless Health at the Food and Drug Administration. The idea being to not expand the mandate or responsibilities of the FDA, but rather clarify and simplify the existing regulations, which goes back to some of the stuff that I was talking about. And the FDA has a number of different initiatives and different things that are all related to either converged medical devices or wireless health within the CDRH and outside of the CDRH, which is important that they actually consolidate these efforts. So I think that goal is marvelous and definitely supportive of it. They're also looking to establish an mHealth developer support program based out of the ONC to help that garage entrepreneur with either a national hotline, educational website, and a yearly report to translate how mobile apps get on the market. They're looking at instituting a disruptive technologies prize program, much like the X Prize Foundation. They're looking at a challenge grant program, low-interest small business loan program, tax incentive programs for medical care providers to deduct costs of non-EHR health information technologies, which, it rings very big in my eyes. And also a workforce retraining 2-year grant program to assist medical care providers to retrain their employees into new positions that use health information technology. So, on its face, as Qualcomm, I absolutely support the goals of this bill, and I hope the industry will also. So I just wanted to make sure that people knew that it existed. I think it's HR 6626, if I'm not mistaken. Name of the bill is the Healthcare Innovation and Marketplace Technologies Act. HR, I believe it's 6626, but don't quote me on that. But if you can, tweet it. Please tweet it. Get it out there. It's important.
So just a quick question. I know some of the payers in their projections are doing on the health insurance exchanges, looking at the low silver to the rich silver plans that they're looking at, a move of higher paid demographic to narrow networks, but more importantly to a less rich co-insurance and a higher copay. Some of the projections I'm seeing is $60 for PCPs, up to $90 to $100 for specialists. So within that realm, is there opportunity for mHealth engagement with physicians for them just to take a cash pay at $60 or $100 and not even adjudicate it for a CPT code, and now we've really engaged the use of these as extended engagements without having to worry about CMS catching up or the payers catching up?
I actually don't know how to answer you. I like it, but I don't even know how to wrap my arms around that. But I'd love to talk with you afterwards. How's that? Yeah.
So any other questions or comments? Anybody? And if not, would you guys like to make any final comments, maybe on, let's say, the future outlook of mobile health? What are we going to be talking about when we're here back together, 3 or 5 years from now?
I would personally like to see what the mHealth task force that the FCC had this summer. They came out with findings and recommendations for the FCC on mobile health, and one of them was an overarching goal that within 5 years, mHealth would become part of medical best practices. I like that goal.
I'm trying to think of goals. I'd like to see a standard form of BYOD. I think that's also been a hurdle for all of us, and there really isn't terrific guidance out there for a standard bring your own device policy. There also really, we look at your patient engagement framework, we don't have a patient engagement strategy best practice. So I'd like to see, some examples sort of percolate to the top. And offer guidance to the rest of us. It's interesting to see when you look at health exchange prior to mHealth, and you look at the varying rates of adoption with electronic health records and health information exchange. It varies. I live outside of Philadelphia, and we're really the tale of 3 or 4 or 5 states. It's so different when you look at different geographics and other demographics, how this technology is being used and developed and leveraged. I'd like to also see further clarity from the federal government. I think the FDA guidance is going to go a long way to provide that. And I think the FCC is moving more quickly, more definitively. Again, I mentioned the wireless spectrum vote that came. And I would look to further clarify our reimbursement and other regulatory environment and how to allow it to catch up to the technology around telehealth. We cannot sustain the coming avalanche, if you will, of a long-term care population within a traditional long-term care facility. We have to facilitate aging in place, and that has to be done through mobile and telehealth, connected health. And I think what we're going to need to have for that to happen is true reimbursement reform. Right now, I believe only 16 states have adopted parity for Medicaid in terms of offering full parity between an inpatient visit and a televisit. I was happy our governor in Pennsylvania was one who signed legislation allowing that in Pennsylvania just this summer. But that gives you an idea how far we still have to go. And I would challenge this entire room to get involved. Listen to folks like Jaron who know their stuff in terms of public policy and some of the public policy makers that are trying to do the right thing, and let's support them.
All right, we're going to have to let that be the last word. So please join me in thanking our panelists.